picture this. A patient comes into the ER with abdominal pain. You lift their left leg and bam, suddenly they're complaining of sharp pain right up in their left shoulder tip. So why exactly does that happen? Well, it's the classic Kerr's sign. Basically, blood pooling under the left dome of the diaphragm, which is super common with a ruptured spleen, shifts when you lift that leg. It irritates the phrenic nerve, and that refers the pain straight up to the shoulder. It's just a brilliant, immediate physical indicator that you're dealing with splenic trauma.
Okay, let's dive into our roadmap for today. We're going to hit anatomy and ligaments, functions and anomalies, cysts, aneurysms and abscesses, splenectomy indications, and wrap it all up with postoperative complications.
All right, part 1, anatomy and ligaments.
So the spleen's long axis literally sits right along the 9th to 11th ribs on the left side. Think of a right-handed cricket player taking their stance. A fast bowler hurls the ball, and it hits the batsman directly on those lower left ribs. Ouch, right? But medically, that specific fracture zone is a massive red flag for splenic injury. Now, when a spleen enlarges, it actually grows medially, not downwards. Why is that? Because the phrenicoelic ligament acts like a hammock, specifically stopping any downward displacement. In the OR, we also have to be incredibly careful with the gastrosplenic ligament, since that holds the short gastric vessels. And the lenorenal ligament? That one houses not just the splenic vessels, but the highly sensitive tail of the pancreas.
Now, looking at the splenic artery, there are two major variants you absolutely have to know for surgery. In about 30% of folks, we see the magistral type. This is where the artery divides into its polar and terminal branches really close to the hilum of the spleen. But in the majority, 70% of patients, we see the distributed type. That's where the artery divides much, much further away from the hilum. Knowing which type your patient has is absolutely crucial because it tells you exactly where you can safely ligate those vessels during a splenectomy.
Moving right along to section 2, functions and anomalies.
First off, we all know the spleen is a huge player in immunity. Pumping out IgMs and IgGs, it filters out abnormal red blood cells and acts as this massive reservoir for platelets. But here's where it gets interesting. We really need to distinguish between two key anomalies. On one hand, you've got spleniculi. This is congenital accessory splenic tissue, usually found tucked right at the hilum. If you're doing a splenectomy for a hematological issue like ITP, where the spleen is basically destroying platelets, you have to actively hunt for and remove any spleniculi. If you don't, the disease is just going to come right back. On the other hand, we have splenosis. This happens after trauma. Say a spleen ruptures, tiny splenic particles can actually spill out, seed themselves in the bowel, and grow into these tumor-like nodules. It looks totally terrifying on a CT scan, but a biopsy will show you it's actually just healthy splenic tissue that got relocated by the trauma.
Okay, section 3, cysts, aneurysms, and abscesses. Pay attention here because this stuff shows up on exams all the time.
Let's break down the two main types of splenic cysts. True cysts, well, they have an actual epithelial lining. And surprisingly, the most common true cyst here is a parasitic hydatid cyst. No way, right? If it gets too large and symptomatic, the spleen just has to come out. Pseudocysts, though, have no epithelial lining whatsoever. They almost always pop up as a direct result of trauma, and the vast majority of the time, we just manage them conservatively. No surgery needed.
Now, what's really interesting about this next bit is how incredibly specific the triggers and management are for each pathology. Take splenic artery aneurysms. This is actually the most common visceral artery aneurysm, usually sparked by pancreatitis. But here's the absolutely crucial and honestly terrifying part. The highest risk of it rupturing is during the 3rd trimester of pregnancy. That makes it an absolute obstetric emergency, and you need a CT angiography, STAT, to diagnose it. Then you have splenic infarcts, which are typically tied to portal hypertension and cause that pleuritic left shoulder pain we talked about earlier. Finally, splenic abscesses. You're really only going to see these in immunosuppressed patients. The rule of thumb here, if it's just a single unilocular cavity, you can drain it with a pigtail catheter. But if it's multilocular, meaning it has multiple little pockets, you have to take the whole spleen out.
Which brings us nicely to section 4, indications and splenectomy.
So when do we actually take the spleen out? Trauma is still the #1 reason, hands down, whether it's a nasty car accident, a sports injury, or even just accidental operative trauma. We also do it for hematological conditions like idiopathic thrombocytopenic purpura, or ITP. Oh, and a quick high-yield clinical pearl regarding ITP. Because the spleen destroys platelets in this disease, you must wait to transfuse new platelets until after you have ligated the splenic artery. If you give them too early, the spleen is just going to instantly destroy those new platelets too. Other indications include sinistral or left-sided portal hypertension and malignancies like lymphoma. All right, so how do we actually pull this off? Whether you're doing it open or laparoscopically, there are 5 main steps. You dissect the spleen, free up those lateral retroperitoneal ligaments, carefully transect the hilum, dissect the short gastric vessels right along the stomach's greater curvature, and finally, extract the organ. But remember that anatomy we talked about earlier? You have to be so careful. Dissecting near the hilum and the leorenal ligament puts the pancreatic tail right in the crosshairs. If you happen to injure that tail, your patient is going to develop a pancreatic fistula, and you'll see this amylase-rich, turbid fluid just pouring into your surgical drain post-op.
Finally, Section 5. This is the big one, post-operative complications.
And this brilliantly illustrates exactly what you need to be watching for and when. Intraoperatively, you're obviously watching for primary hemorrhage. Within that 4 to 24-hour window, a reactionary hemorrhage from a slipped ligature is your absolute worst nightmare. But look at post-op day 1. Left lower lobe atelectasis, which is basically the collapse of the alveoli, is literally the most common complication overall following a splenectomy. Because the surgery happens right under that left diaphragm, it hurts to breathe. Patients take shallow breaths, and that left lung base just collapses. If you don't aggressively jump on that with chest physiotherapy right away, by day 2 or 3, it's going to evolve straight into pneumonia.
Now let's talk numbers. Remember how the spleen is basically a giant storage tank for platelets? Well, when you take it out, all those platelets flood the system. If that post-op platelet count crosses the 1 million mark, that's 10 lox per cubic millimeter, you've got a massive problem. The patient enters this highly dangerous prothrombotic state. The second they hit that exact threshold, standard guidelines say you have to start them on prophylactic aspirin immediately to prevent deadly clots.
You're also going to see some really distinct permanent changes in the blood. For the rest of the patient's life. If you look at their peripheral blood smear after a splenectomy, you are forever going to see Howell-Jolly bodies, basophilic stippling, increased reticulocytes, and hypersegmented white blood cells. Without the spleen acting as this meticulous filtration system, basically a graveyard for abnormal cells, these microscopic oddities are just allowed to circulate freely forever.
But without a doubt, the most feared long-term complication is OPSI. That stands for opportunistic post-splenectomy infection. It's a highly lethal infection driven by encapsulated bacteria, specifically pneumococcus, Haemophilus influenzae, and meningococcus. The risk here is highest in kids, peaking in the first 2 to 3 years after surgery. And ironically enough, the risk of OPSI is actually way higher when you take the spleen out for hematological conditions compared to trauma. Why? Because in a trauma situation, surgeons are rushing to save a life, and they might accidentally leave a microscopic piece of splenic tissue behind, which actually gives the patient a tiny bit of residual immunity.
Because OPSIs is just so incredibly dangerous, strict vaccination protocols are an absolute must. And timing? Timing is literally everything here. If you're doing an elective splenectomy, you have to vaccinate the patient at least 2 weeks before the surgery. Letting the vaccine take effect while the spleen is still in the body generates much higher, more protective antibody titers. But if it's an emergency trauma splenectomy, you obviously don't have that luxury. You just have to give the vaccines on post-op day 1 or 2 as soon as humanly possible, even though you know those antibody titers are going to be a lot lower.
Okay, I have to throw in this surprising, incredibly high-yield fact. Let's say your post-splenectomy patient goes home and gets a simple dog or cat bite. Well, they are in extreme danger. Without a spleen, they are wildly susceptible to a severe, incredibly rapid infection from a specific bacteria found in animal saliva called Capnocytophaga canamorsis. Beware the bite is literally a lifesaver for these folks.
It really makes you think, doesn't it? If a single organ dictates so much of our immunity, manages our platelet count, and shapes the whole intricate anatomy of our left upper abdomen, are we ever truly the same once it's removed? The human body adapts, sure, but it leaves permanent markers behind of what was lost. Anyway, I really hope this explainer gave you a rock-solid, structured mastery of the spleen and everything you need to know surgically. Stay curious and keep learning.